Rating today's session. All right, let's continue with the recording. Today's session is Precision Public Health, Transforming Health with Data. This webinar is part of a series that Dr. Jeremy Lim will tell you more about. It's called Healthcare Executive in Asia Leaders, or HEAL program, and is supported by the Temasek Foundation. Thank you to Temasek, in partnership with the American Chamber of Commerce in Singapore, which I represent. I'm also an adjunct associate professor at the NUS Saw Swee Hock School of Public Health, and I'm a trained genetic epidemiologist. It's great to be here with you guys today. Our other panelists are Professor Jeremy Lim, Associate Professor at NUS Saw Swee Hock School of Public Health, Director of the Leadership Institute for Global Health Transformation, also known as LIGHT, co-founder and CEO of Amily, the first dedicated gut microbiome full-service company in Southeast Asia. If you want to know how to spell it, it's AMILI. You can look that up, very cool. And of course, Professor Lim has a special interest in ways that technology can increase health equity and access to care. I'm also pleased to welcome Assistant Professor Nina Schwalb, Principal Visiting Fellow, International Institute for Global Health at United Nations University, Adjunct Assistant Professor at Helbrunn Department of Population and Family Health at the Mailman School of Public Health, Columbia University. Professor Schwalbe also chairs the Evaluation Advisory Committee at Gavi, the Vaccine Alliance, and co-leads WHO's research network on COVID in educational institutions. And finally, we have Professor Gareth Bainham. Thank you so much for joining. Head Western Australian Register of Developmental Anomalies, Clinical Geneticist, Genetic Services of Western Australia, Program Director, Undiagnosed Diseases Program, Western Australia, Government of Western Australia, Department of Health. Professor Bainham also leads the clinical implementation of genomic and phenomic objective phenotyping, digital health technologies, and omics-associated policy. And I had to pull that sentence out of his bio because I'm intrigued by every other word in that, and I'm sure we'll learn more from him later in his presentation. Thank you so much again for joining us. We have a really exciting conversation about precision public health coming up. And so now I'd like to invite Professor Lim to give us the opening about precision public health. Thank you.
Thank you, Xian, and a very good morning or good evening to all of you, wherever you are. I am just starting to share my screen. Just let me know if you can see it up nicely. Xian, everything's good? Okay, so, and before I jump into the presentation proper, let me just share that this is the first in a four-part series. That's supported by the Temasek Foundation, and the impetus for this was really COVID-19, and which as the first pandemic in 100 years richly illustrates how health is in everything, and everything does affect health. So this entire series really explores the impact the impact of decisions taken by leaders across both inside and outside health, and how public health decisions can affect. And interestingly, many investors, many corporate leaders have approached the school to say, teach us more about public health. We've suddenly realized we need to know a heck a lot more than what we used to know, and that it's becoming very critical. And in fact, interestingly, quite a number of colleagues and friends who are in executive search firms have started to ask about this notion of having a chief health officer in large corporates whose traditional businesses have nothing to do with health. So this is our effort to contribute to the really thought leadership and to bring like-minded people together. And as Xian said, today we are starting with precision public health and transforming health with data. We're going to go on next to talk about food and then about urban planning and about this notion of really health promoting cities. And finally, we will end the series by talking about what the Lancet Commission describes as the commercial determinants of health, and hopefully through this mini four-parter, it gives you a nice flavor of really what is out there and how important it is for all of us in health to know about the wider world out there, and for the wider world to know enough about health, because every decision they make, whether to reopen borders, even reopen cinemas, have got profound health impact. So now let's dive into today's topic, which is around precision public health. And I must thank Gareth and his colleagues from Australia who had introduced me to this concept that I was um, really intrigued by, because it's almost as oxymoronic as talking about personalized population health. The whole notion of what we as public health professionals think about is that we care about the health of populations. And in a sense, we necessarily almost have to box people into one box, or one size fits all, or into a finite number of boxes, because it's just pragmatically easier, right? But I hope that after this 90 minutes webinar, you're firmly convinced that we can break out of this traditional paradigm, right? And really truly talk about precision public health, because today's technology does allow us to do so in profoundly different ways. So what is precision public health? There are many definitions. Let me just simplify it by borrowing from Nguyen, who is the head of the who is head of the CDC's Office of Public Health Genomics. And essentially it's about the right intervention at the right time, every time, to the right population. And as Nina will share, and Gareth too, there's a huge component around the digital signatures of individuals, the use of geospatial location, and really infusing genetics into this. So it's so precision public health is not narrow, it's very holistic, and it takes the sum total of the information we have about individuals, about populations. So how then do we make it real? But before I go into that, skeptics have said that precision public health is really old wine in new sheepskins, and that it's really nothing, and it's really no big deal. We've always wanted to be precise. I mean, it's almost like really precision medicine. Which of us as physicians don't want to give the right treatment to the right patient every time? Uh, what I would submit to you is that this time round, it's different. And it's different because the technologies and the data sets allow us to think about public health in completely different ways. Um, Many of you will be old enough to remember the era of broadcast television, right? Where you would, and those of you really old enough will remember the series Dallas, and how Who Killed J.R. Ewing was the talk of the town for months and months, because uh, it just had to be one size fits all. The really broadcasting service pushed out soap operas and other content at a fixed time, and you caught it or you didn't catch it. And then comes along Netflix, comes along Disney Plus, and it essentially offers you the opportunity not just to have content at the time that you want it, but content that's tailored and customized to you. So we live in a world that's very different if we look at it from a data perspective, right? And think about it in terms of collecting data, analyzing data, and using data all in real time. So advances in computing, advances in sensor technology, advances in connectivity allow us to think about public health in completely different ways, and hence public health truly this time has the opportunity to be precise. So what's happening around the world? I have put up this slide just to really quickly illustrate the point that precision public health is not something for the rich world. Yes, very wealthy countries like the US can infuse programs like All of Us research, where there's genetic sequencing, digital phenotyping, and so on. But even in the so-called developing world, in low and middle income countries, it's really around using data to make better decisions at the individual and at the community or at the population level. And 2 years ago, the Rockefeller Foundation launched a $100 million Precision Public Health Initiative. And essentially, in my conversations with the Rockefeller Foundation, it was really crystallized into, we have 10 nurses, we have 1,000 patients, where should these 10 nurses go? And that's as simple as it gets, but yet so important and so profound. So let me whiz through a couple of examples, because really my role to kick this series off is really to give you a sense of the breadth. And, and I thought I would start with personalized population health and breast cancer screening, right? We're all familiar with breast cancer screening guidelines at our age, and And the better guidelines would try to divide individuals into normal risk and high risk. And the wisdom study, one of the more recent studies, really tries to look at individual risk based on really genetic profile, based on family history, and then customize what is the screening regime that would be appropriate for this person. And if it works well, then we could really think about how to screen in much more efficient ways. And remember that at the population level, national or global screening programs, making one small change, removing one screen affects millions and potentially billions. So the savings in time, the savings in really resources are truly massive. And this then allows these resources to be channeled elsewhere. Um, and I know Nina's going to talk a lot about the geospatial focus. Let me just share this slide that's from the Bill and Melinda Gates Foundation. And it made the observation that 90% of the disease burden um, spread by the mosquito, the Aedes aegypti, can be managed by focusing on 14% of the total surface area or the total land area across the world, right? And this sort of overlay of geospatial and other data points onto traditional public health issues gives us a lot of potential to have a much greater bang for buck. And trust me, in the world of public health, as COVID is again richly illustrating, resources are very, very finite. Demand is finite. But demand, whether it's for testing, whether it's for vaccinations, is potentially much, much larger than that. So I wanted to share a little, and this example would be familiar to many Singaporeans because this was launched last year, and it's a joint effort between Apple and the Singapore government, represented by the Health Promotion Board. In a nutshell, it's personalized health promotion. Think of all the spooky, potentially sinister nudges that social media may push to you to get you to click like, to get you to watch one more video. And ask yourself, if we took all these lessons and applied them to do good things, to nudge people in real time at scale to improve health, right? Can we do that? And that's what this Lumi Health initiative is really all about. It gamifies health, offers persons the opportunity to take part in social challenges, to earn points, and to then get rewards, right? And in a year or two, we will have very rich data as to understand whether this works and for what sort of populations that this works well in. I do want to talk about mental health a little bit also because this is all of the rage, and rightly so. Mental health has been characterized by being difficult to study, being expensive, and quite interestingly, technologies allow us for the first time to think about population mental health surveillance passively, meaning there's no active intervention needed, at scale and quite inexpensively. And I wanted to introduce this notion of digital phenotyping. And I think that the Onella definition that comes out of the T.H. Chan School of Public Health is a good one. It talks about the moment by moment quantification of individual level human phenotypes from personal digital devices. Now add up all of this and we have population mental health surveillance. And in the two examples that I put out here, the first is a voice-based classifier of PTSD that has been validated and used, and this dates back to 2012. Today we have startups and young companies such as Mindstrong, which is a company in the US that looks at one's use of a personal digital device. How many times you swipe, how many times you turn on, what are the haptic pressures, the error rates, and really so on. And this then gives a sense of the individual's state of mind. And again, accumulate all of this, and can we passively conduct mental health surveillance at the population level, especially high-risk populations, young people, migrant workers, and really so on. So I wanted to end off with a last example, and I took this from a friend in Deloitte. Because Deloitte is doing a lot of work in rolling out the vaccine programs in the UK, in Australia, New Zealand, and so on. And I asked them to look at the hesitancy analysis out of social media. And and very interestingly, in the interest of time, I'll move to this one. If we look at Singapore's data, starting from August through to February, the share of topics around vaccine hesitancy evolves over time, and time doesn't permit us to look into the details, but social media tracking gives us a good flavor, limited, one of many data points that we need to build in, but it gives us an understanding of the initial concerns. And as we as public health professionals think about vaccine rollouts, we need to match demand for vaccines with supply and with the capability of the vaccination center to roll out. So it is a disaster given the logistical challenges with the Pfizer and with the Moderna vaccines. If we think that 1,000 people are going to show up, but only 500 show up, then there'll be 500 vaccines wasted, and this just would be such a real pity when the world is so short. And so the challenge then is, can we predict out of all the invitees, how many are really going to show up by mapping social media commentary and other data points with the location around the vaccination center, those and hence get a better sense, a more accurate sense of what the true demand is, right? And then match it better to supply. And lastly, overlay the competency or the capability of the individual vaccination centers, because you may have 2 vaccination centers with exactly the same resources, number of doctors, number of nurses, but their productivity can be very, very different. And again, we are in a pandemic that all of us are desperate to get out of. We have to use the vaccines, the limited ones we have, very, very wisely. And this is one example of what technology can do. So I wanted to close with this, since I just had to spend very good money to subscribe to Disney Plus for my youngest kid. I wanted to show those of you who are of my vintage will remember the movie Minority Report, where the system predicts who is going to commit crimes and preemptively and proactively arrest perpetrators before the crime is committed. And I wanted to share that as we move into the era of precision public health, remember that the mind of man is capable of anything. We must not just embrace technology, but bring in the ethical conversations, set in place the guardrails, because with great power comes great responsibility. And on this note, thank you very much. I'll hand the time back to Xian. Thank you, Xian.
Thank you very much, Jeremy. You've covered a wide range of tools, technologies, various disease states. It's going to be very interesting to look into it more deeply. And we already have a couple of questions. I myself have a number of questions, but I think it would be best for us to have all of our speakers go through and share with us their point of view on precision public health and the work that they have been doing, so we get a bigger, broader picture of precision public health. Then let's bring everyone together for the discussion. So next, I'd like to invite Professor Schwab to share her thoughts on precision public health.
There we go, unmuted. Great, that's a relief. Thank you so much. I'm really pleased to be here with you today. Sorry, I just have a small, just gotta fix my Zoom stuff. Sorry about that.
Your slide looks great from our side.
It's just frozen. There we go. Is that the front slide? Is that
Yes,
what you're seeing?
Looks
excellent.
Good.
Thank you so much. So I would like to thank Shen and Eliza and Jeremy for inviting me here today, the Sasi Hawk School of Public Health, and also AmCham Singapore. It's a real honor to be speaking to you from New York City. Jeremy gave a great introduction to what is precision public health, and for me, what's so exciting about it is this ability to target interventions to focus on reducing health disparities and really use multiple types of data to better allocate resource and better, ideally, improve health outcomes. A lot of the words in the center of this slide were used in Gareth's introduction, so I won't even attempt to try to pronounce them. But again, as Jeremy put it, the idea is right time, right place, right approach, and we hope that these data will inform and actually improve decision making, because resources in health, at least until the beginning of COVID, were extremely limited, and we have to maximize not only those resources, but also time and effort. So this idea of risk stratification, so how do we figure out who's most at risk and what do we need to do to reduce their risk? On a very basic level, I think I first really visualized this idea just by using basic maps. And this was an example from Malawi. I worked at UNICEF for many years, and it's sort of saying super simple idea. Instead of looking at national averages, we have to look at what's happening district by district. And then we know that instead of doing a national program, for example, to reduce under 5 mortality, we can really target our resource to district at highest risk, which is the dark centered slide, and dig down deeper on what's actually going on there specifically. If you'd asked me to speak a year ago, I think literally a year ago, I would have been an incredible evangelist for all the technologies at our I'm still an evangelist. I just am focused on other things, but I would have been an evangelist of all the promise of geospatial mapping, the Internet of Things, the example that Jeremy just gave, genomics, and how we can be really precise and understand how diseases are traveling and what individual level things are happening. And also just the use of electronic health records, which are now pretty pervasive, and the ability of them to help us pool data, get big data, and share data. Now, of course, data sharing, and I think we'll get into this in the discussion, one of the barriers for precision public health is the challenges to data sharing. There are technical challenges, motivational, people don't always want to share. Some people own data, so the idea of data sharing is problematic there because they want to sell it. There are political challenges, people don't want to share their data because it shows bad things about them, legal challenges on individual basis, and then sometimes ethical of selling people's data without their permission. And I wrote an article last year in the Lancet on the use of AI for low-income countries, filled with promise, and on data and data sharing and governance. And then COVID-19. And I'm going to give you an example. And I realize, again, I'm extremely honored to be speaking to you. Today, I was looking at the numbers of Singapore, at least according to Our World in Data. You've had 29 deaths, which is tragic. And I'm sorry, deeply sorry for every family that's lost a member of their family due to COVID. To just put that in the perspective of New York, you've had 29 deaths in Singapore. We've had 29,000 deaths in New York City alone, just in New York City. And a lot of that happened quite early in the pandemic, but not only. You have a population of about 5.7 million people, according again to the internet, I hope that's correct. And we have a population of about 8.3. So certainly not to justify that order of magnitude of the number of deaths. So I want to talk to you a little bit about vaccine distribution in New York, which is something I've been quite involved in. I've worked in global health my whole life. I was actually supposed to be in Malaysia all month at the United Nations University. And in the last year, I've been grounded, as we all have, and really focused my efforts locally on New York City and New York State. And so, as you know, the vaccine just rolled out. We got our first doses at the end of December, and it was very limited. The eligibility were very limited in the beginning, and then suddenly expanded for political reasons quite wide. So we have 14% of New Yorkers have been vaccinated already. We have about 4.5 million New Yorkers, 4.5 million who are eligible despite limited supply, and people there's been a number of articles which have been called the vaccine hunger games because of how people are trying to get vaccinated. So let's go back to the data and what we knew, and maybe how we could have done this better. So what we know, this is data from the CDC. Can you see your faces on the top of the screen when I screen share, or just the slide? No, just the slide.
Just the slide.
Excellent. So what we know this is a slide from the CDC. What we know about deaths in America are that older people, 65 and older, are considerably more likely to die of COVID if they get COVID, to factors of up to, almost 8,000. So incredible risk here. And we know that that's also the same for New York. So this slide shows what's happening in New York City, or what's happened in New York City. This is a rate per 1,000 in the population, and we see exactly the same as what we see nationally. We see that older New Yorkers are at much higher risk. Similarly, this is what we know from the CDC, which is our National Disease Control Agency, around risk of death by race or ethnicity. We know that people who are Black or Hispanic are at least 2 to 3 times, or 2 to 2 times more likely to die from COVID. And we again see that exactly the same in New York, as evidenced by this slide. We also know a lot about who lives where in New York City and where people are dying. We have very strong, we've always had a commitment in the city to equity in terms of how we think about designing our public health program, and collect data at a very granular level, which is then made widely available for analysis. So what you see on the left here is socioeconomic status and race. And the top dark green is the darker or richer areas of New York, and the darker purple or whiter areas of New York, which is also associated here with socioeconomic status. And on the other side, the pink side, what you see is the deaths. And what you would expect to see, I guess, given that we have racial and social inequity, in particular in New York City, but also across the United States of America, is you would expect to see just what you see here. The richer, whiter parts of the US are less likely to die. They're not in the high mortality areas of New York. And we have data on other social determinants, which we can also map together. Rent burden households was a very important statistic or data source to look at early in the pandemic because of household crowding and what we knew from the early Wuhan data about close household contacts. Similarly, we know data on race, and the bottom we know about people's professions. So then the question is, what does this do to inform our decision making? So we know a lot about the data on vaccine, on who's dying, where, and why. So this is a slide I pulled up. I have come to a strategic decision. I'm going to pretend the data don't exist. And that is unfortunately pretty much what we've seen in New York. And this is an example. So on the left, we have the people who, the districts that have a higher concentration of receipt of first dose of vaccine. This is population adjusted. And on the right, we have that same death rate. So what we would hope to see here is that the darker areas in the blue would correspond to the darker areas in the pink. That would mean that we were vaccinating people in the highest risk districts. Unfortunately, and I've circled 2 examples, that's not what we've seen. This is a very simple way. This isn't particularly precision public health. This is just normal, boring old public health. But we see that in New York, 55% of the population is white. They represent 40% of those 30,000 deaths, but 78% of people who've been vaccinated. If we look at the Black population, they represent 14% of the total population, 23% of deaths, so they're overrepresented is what we say in public health. We would expect them, all things being equal, to have the same percent of deaths as the population, but that's not true because of the social determinants and inequities, and only 9% of those being vaccinated. So, and I think going back to Jeremy's boxes, we have a lot of boxes which give us a lot of data, and we have a lot of data on a lot of determinants, and somehow we really just have failed in using precision public health to deliver vaccines in New York City. Now I'm going to give you a slightly more positive example, I hope, or one that I hope will end up being a positive example. Again, I don't know, I only read sort of the Lancet. I've really restricted my reading to one journal, a couple. So I don't really read the news, but sometimes I pick it up or see it in the morning. My kids are reading the newspaper. And schools are a big deal here. The evidence, and I chair a committee at WHO on evidence around schools, the evidence basically show around the world that that schools are a reflection of community transmission. They don't drive community transmission. But there's a big panic around what happens when we send our kids to school. And as part of that, very early in the pandemic, there was a decision in New York City that any 2 cases in one classroom would close the classroom, and any 2 cases in the school would close the school, and the school would have to quarantine for 2 weeks. So we have about over 1 million kids in New York alone, and about 25% opted for in-person learning. You could opt either in or out. The graph here is the data from the Department of Education website, which we've made as public health people a prayer to the new mayor to say, please bring health back to the Department of Health, because these data are certainly not precise enough to be very helpful. If you look at the number of schools that have closed, it's wild and all over the city. And schools are closing like ping pong balls because of this definition of cases, 2 cases in a school. And our hypothesis as public health people is that, and what we found from the contact tracing when we do it after the school closes, because that has to happen after the school closes, is that those cases are unrelated. So 2 kids come to school infected and happen to be in school, but this is not an outbreak in school. And what's really exciting, and this is where I'm very positive, and maybe Gareth and Jeremy, you can put together a Singapore program to come help us in New York, but we have some new labs in New York City which are going to use genomic sequencing to sort of prove that these outbreaks, and have started to show that these outbreaks are not outbreaks. They're different cases that are both being brought to school, but it's not an outbreak within the school. So we're extremely excited about this program moving forward. So I think our challenge here is sort of how do we get the data ball rolling up the policy hill? And Sisyphus, was always rolling that ball up the hill. And this cartoon says, when you've got a minute, I'd like to discuss progress with you. And, we don't feel like we're making very much. And I think the first challenge that we face is how do we convince policymakers to follow the data? The example I showed you was really clear. It wasn't rocket science. It wasn't AI. It wasn't machine learning. It's just sort of mapping and zip codes and geospatial planning and death data. It's pretty simple stuff. But unfortunately, it doesn't seem to be driving decision making. And that's something that I think we just weren't expecting. It took us by surprise. And then I think this idea about how do we share data, and certainly in the beginning of the pandemic, that's been very hard, and particularly around hospital data and death in New York. I think what we've learned here is that we have such a decentralized system of healthcare, and it's so privatized that it has been really hard to get people to share data. And I wanted to take that out, that is not only here. There's a website called Global Health 50/50 that looks at gender data. And I mean, I'm just shocked to see that out of the 192 countries that report data to the UN, really just a little over half are reporting sex disaggregated data. So I think also there's going sort of back to basics about if we really want to do good global precision public health, we have to figure out ways to incentivize people to share data, both big data, AI, machine learning, all of that, so that we can do some of the sentiment analysis that Jeremy spoke to, but also small data like gender. So with that, I'll end, and I thank you for your time.
Thank you so much, Nina. I know you said that some of the data you show was normal, old, boring public health, but you got me super excited about public health again. Just looking at, very basic percentage of death, mortality rates tells us so much. And with precision public health, the world of possibilities seems endless. And with that, I'd like to invite now Professor Bainum for your presentations and point of view on precision public health.
Thank you very much. There's beautiful talks by Jeremy and Nina. It's such a brilliant work, and thank you so much for the invitation. I'm having a tech fail here. I've managed to share my screen, but now I can't scroll through my slides. So I'm just figuring out why that is the case. Oh, here we go. It's just a lag. Okay, good-o. So you can read this far faster than I can talk through it. And I think really skipping to the bottom of this, thinking about one planet and one human race, and really what perspective does when we lift our eyes and think about the globe and our diversity and our commonality. This is, of course, a quote from a space traveler, but it's not from an astronaut. It's not from Buzz Aldrin or one of the other three that landed on the moon. It's in fact from Stephen Hawking. And Stephen traveled with his mind through space and in effect through time. And I want to take one perspective. I'm going to talk very little about genetics or genomics today, despite being a geneticist who does genomic stuff. I'm going to talk a little bit about rare diseases, which are paradoxically really common. And we know that up to half, 50% of inpatient hospital costs in the US are attributable to rare diseases. We know that in Ireland, 6 in 10 deaths are attributable to rare diseases, and 9 in 10 hospital inpatient bed days are attributable to rare diseases. And these numbers are similar across the developing countries. And it'll be increasingly the case in low and middle income countries with demographic transitions. We also know from last week that the cost of rare diseases, direct and indirect costs, was 1 trillion, or just under $1 trillion US in 2019. So more expensive than cancer, diabetes, Alzheimer's, heart attack and stroke, etc. If we put all the different rare diseases people together, each living with one of their many different, up to 8,000 rare diseases, and we stuck them in a country, that'd be rare disease land, and it'd be the 3rd biggest country in the world. So China, India, rare disease land, everything else. For people with rare diseases or more common diseases, many things are about finding the right path. And if you don't have the right language to have the discussions, to make the understandings, then how can you navigate? How can you have the right path? How can you get accurate information about vaccines, or dispel myths about vaccine uptake, or about vaccine side effects, or Wi-Fi, or whatever the messaging might need to be? So in 2019, as part of the United Nations International Year of Indigenous Languages, we started thinking about building a universal Indigenous medical translator. And so we reached out to UNESCO and said, can we do this as part of, will you endorse this? And very gratefully they said yes. And so we thought, well, how are we going to do this? We think it's really important. We need to sort of reimagine how we can do this, at scale. Because there are 400 million people, or just under, who speak an Indigenous language globally. It's all about making healthcare more accessible and reducing health inequities. So we thought, well, why don't we connect to youth, to multiple generations, to their senior community members and their elders? Because if so, we can transmit knowledge across generations, we can help retain and empower language, we can reconnect to culture, and so every age will feel good about that. So we started by identifying champions, and this is Yalaloo Thomas. He's an incredibly remarkable medical student, come so many other things. And so we supported him to really work in this space and start the Life Languages program. And also, which is what we've called this program, and also to blend that with other technologies like facial analysis. Anyway, so Yalaloo started, and you can see the little red circle in the middle slide, the block. This is 300 kilometres east of a place called Port Hedland, which will take you about 22 hours to drive to from our capital city, because we are the world's single largest public health jurisdiction geographically. We've got about a kilometre squared per person. We have 2.5 million people and 2.5 million square kilometres. And really, he worked with his community to do these translations. And then several other champions, Indigenous champions across Australia, joined in to work on other languages. And then it spread internationally. So these are some of our Ghanaian life language champions. And in this case, we see people who are, they're mental health experts, they're allied health experts, they're computer scientists, they're doctors, they're media and promotions people, all working together with a shared purpose. And then it was like, well, there's all this human effort going, all this hand jamming, all these Excel spreadsheets and whatnot. How do we scale this? So then it was about the digital health piece and what digital technology can we use to aggregate and present this information in different ways. So then we started bringing together these different youth and their community members. And then we started first with a language, Nyangamara language, which is Yalaloo's language, and Twi, which is the most prominent Indigenous language in Ghana. And then really sort of built a portal, and this is the first stage of an app, to really sort of aggregate all those translations and then provide ways to represent that information for whatever use case you wanted to, because it's one thing to ascertain a translation, it's another to implement it, and it's another not to burn out people doing the translations. So this is a way to re-implement for whatever public health issue, whatever disease domain, whatever age stage you wanted, and also to build education resources discreetly around that talk in Aboriginal or Indigenous narratives. At the back of this is how we manage the knowledge. So we also wanted to make this all computer readable, so that we could bring in other technologies. We could combine it with genomics or facial analysis or with AI and text mining. And so at the heart of this, you can see we take the medical terminology. Here's macrocephaly, big head. Here's the lay translation, big head. Here's the Nyangamata word for big head, Jentuwertu. And here's the computer readable standardized term, HPO 000256. So then we can fuse community knowledge, medical knowledge, and technology to deliver solutions. And everything's about trust. Nothing is as fast as trust. Nothing is as inspiring as trust. Nothing is efficient and sustainable as trust. Or if you want to talk about, was it the commercial determinants of health? I love that term. Then nothing is as profitable as trust. Another trust mechanic was really about, which uses spatial technology blended with other things, is this incredible thing called Mapper. And what this was where the community again is aggregated to provide solutions using precision health technologies. So in the first instance, we talked about this language and this build out of this universal Indigenous translator, which we then applied to COVID messaging and, for instance, implemented COVID messaging in communities within 48 hours from deciding to do it to disseminating it throughout the communities in multiple different languages, in the supermarkets, in the community locations, etc. This is another solution where the community has got together and built the solution. So this is the Aboriginal Health Council of WA, represents all the Aboriginal health controlled organisations, which are all the medical providers of healthcare for Aboriginal people dispersed against that 2.5 million square kilometre space. And so what they really wanted to do was to use spatial technology combined with other technologies to get the right care, right place, right time. To help with referrals, identification, travel, follow-up, care on country so you don't have to travel, and more culturally appropriate care. To do things to build in things like, what are the weather and road conditions like? What are the ceremonial times that will prohibit you from going to a certain place at a certain time? When is the next visiting specialist going to arrive in our town for our heart service? So, for instance, this is a satellite view of the Mapper platform. You can see there's a whole host of medical providers in there, be they Aboriginal controlled health organisations, be they hospitals, be they mental health, be they drug and alcohol, be they visiting specialists, all aggregating the data into one place to make it available for patients and clinicians to use. And so this is if you drag down to a particular, this is Werricka. This is the local health service to Yallaloo's family. And if you want to know when cardiology is next visiting and where the nearest clinics are that they'll be visiting to where you are, then you can, for instance, put in cardiology and put in your location, and it'll bring these up and it'll tell you the times, the places, who's coming, etc. It tells you about place and what's actually in those services. It tells you about what the services provide, who they're staffed by, what their telehealth options are, what the cultural elements and the weather elements are. It builds itineraries for you if you need to travel. So, for instance, if you wanted to go from Port Hedland to Perth, you would then have a 2 hour. You would have a bus followed by a 2 hour flight, followed by a taxi, followed by a walk, and it will plan it all out for you. And then again, to build trust, what's the cultural elements? What are the specific elements of the community and about how you engage with the community, so you know those in advance, so that you can adapt your delivery style, your communication to that. Because in the end, if we don't approach culture and we don't work with culture, then we can't deliver the most efficient care. So then really what we do is start to merge these different technologies, these different precision public health technologies. So right now we're merging Mapper and life languages. So for instance, when you go into life languages and you drill down to sections, you'll have translations of various sections in language depending on who you are and where you're coming from. We blend it with our 3D facial analysis technology, for instance. You remember I showed that there was this computer readable code, this precision medicine lingua franca called the human phenotype ontology. Our facial analysis also spits out these terms. So we can take a 3D photo of a face and spit out standardized text descriptors, which you can then fuse with text genomic information or text mined information. So we combine face, space, and place. And really that's about capturing, harnessing, working with the voice of the people, the voice of the Indigenous people, the voice of the doctors, combining with ancient wisdom, building in new technology to give us answers, community, and empowerment. It's artificial intelligence meets ancient intelligence. It's scale and equity. It's immediate and it's sustainable. So my question to you is, how will you help? Will you become a life languages champion, partner to an Indigenous champion to help? Will you support the technology development or the people? Will you think about how this could be connected to other aspects, or how this could be used? Could this be used, for instance, as we're starting to do now for COVID vaccine messaging with our life languages program? As we're starting to do that in Western Australia and in Ghana, could we be partnering to do that elsewhere in the globe? I'm sure there are many other ways that people can help. And so please reach out, and thank you very much.
Thank you so much, Gareth. I want to remind everyone that we are taking questions, so please now take the time. The presentations are concluded by our wonderful speakers, so please take the time to leave your questions in the Q&A. And I do notice a couple of folks with their hands up, so if you wouldn't mind just popping your question in the Q&A, we will definitely get to them. But I'm actually going to bring us back a little bit to a higher level conversation about precision health, just as a reminder. I have to admit, I was a little obsessed over the last year with trying to define precision public health. And then over the last few months and after listening to you speak, I've decided, you know what, who cares? We don't actually need a definition of precision public health because end of the day, there is no clear dividing line between precision medicine and precision public health and traditional public health and precision public health. But then it brings me to the larger question. We have some students and aspiring researchers who are in the audience today. If somebody wanted to delve into the land of precision public health, what is actually the best way for them to get into it? Because I'm looking at all of the work that you all have shared and all of it is so fascinating, but it makes me wonder, aside from the typical public health curriculum, you'd have to be a cartographer, you'd have to be a linguist. It's really intimidating. So where would you advise students or aspiring researchers on how to begin their journey into thinking in the precision public health perspective? Maybe I will start with Jeremy on this one.
Yeah, thanks, Jen. That's a difficult question. I must say that when we define precision public health as whatever works, this really opens up the entire universe. I would really go back to basics and and really start at the important point Nina made, that resources are finite. Demand is infinite, and really it is a moral responsibility of all of us to really channel resources to where they are most needed, with a particular lens for health equity and for reducing disparities. So, and if that's the end point, then there are many roads that lead us to precision public health. And I would urge the young student to get a good foundation in classical public health, because you must stand on the shoulders of giants. Secondly, recognize you have to work as part of a team. Nobody knows all the necessary skills, so learn to work together as part of a team and have that mutual respect. I know it's quite rich coming from a medical doctor when we are used to thinking we're the center of the healthcare universe, but yes, we are trying to change that, and really adopt that stance of humility and willingness to learn and to be wrong, because we are in frontier territory. Nobody really knows what is the right or the wrong thing to do, but we have to do something. The analogy that I like to give is that you're the captain of the Titanic, looking at the iceberg right in front of you. You don't know whether you should turn left or you should turn right, but for heaven's sakes, you have to turn. And back to you, Sian.
Thank you, Jeremy. What do you think, Nina? How does someone get started in the field of precision public health? You're on mute.
I agree with Jeremy that it's quite a difficult question. But I mean, I've been struck also, and I think I have my whole career, by how important the basics of public health are. And I'll give you an example of yesterday. We're doing a study in Elmhurst Hospital, Queens, about vaccine hesitancy. And we've interviewed about 2,000 healthcare workers about how did they feel about getting the vaccine, did they get the vaccine? So there's an analysis, two parts of the analysis is to look at sort of the racial effects, to what extent does race affect vaccine uptake, and what extent does race affect vaccine sentiment? So the reason I say this is I was working with some younger researchers who hadn't really structured in advance the question, the hypothesis. They hadn't really set up the null hypothesis. They did a multivariate analysis where they just sort of threw everything in and then got a bunch of stuff out.
Nobody does that. What are you talking about?
We used to call phishing, and sort of had to really step back and say, what's your hypothesis? What are you trying to disprove? What do you think is the theory? What do you think is a mediator? What do you think is a moderator? And we had to go back through all those language. And so I think really just starting with the basics allows you to pick up the rest. The world is evolving. When I was in school, a couple of people were doing machine learning in the computer lab, but that certainly wasn't sort of household language at that point. So for me, it's about starting with the basics. And I think also and not necessarily the toys. And the other part, I think the most influential work in my career was an article. Again, this is back to Jeremy's sort of leaning on the shoulders of giants, by Mosley and Chen on the social determinants of health. And that article changed the whole way I think, not just about health, but about life. So I also think really digging down on Michael Marmot and the social determinants of health is a very important place to start.
That's great. Michael Marmot, social determinants of health, and null hypothesis. I come from the land of genetic epi where everything's GWAS, and let's just like look to see where things light up. Still can't come to terms with that. Sorry about that. Gareth, what your thoughts on how to get started in precision public health?
I think, precision public health is about equity and it's about scale. It's about doing the most for the most and for the most at need. So if you're doing that already, you're already doing precision public health. And there's so many different ways to do that. And I think we've seen just some of the different approaches, technologies, roots up community approaches that really form part of the nexus that is precision public health. So don't be afraid by it. You're probably already doing it in some way. The other, I think, completely agree. You want good grounding, you want good fundamentals, and you've just got to work in a team. And the most important members of your team are the community you serve. So make sure you're partnering with the community that you serve, and they're telling you their needs that they need solved, and then you go and solve them. The other thing is to think about, don't be afraid of the size of the task, because there's lots of ways to contribute. So for instance, with life languages, it's a big, scary thing. Let's translate all medical terms across the globe into all Indigenous languages. That's huge, right? Where the hell do you start? And then there'll be people that don't even speak an Indigenous language. They might be Indigenous, but they're not speaking any language, but they might want to. So we created ways that people can just translate a word when they feel like doing it at any time. And that just becomes part of it. And guess what? And then you really sort of essentially expert crowdsourcing it. Or you can get very fancy about your level of involvement. So we wanted to make ways that are really easy, that you can use anytime, anywhere, to contribute. So I think you need to just think about Jeremy's comments about Netflix and the previous models. Think about all the innovative ways that you already are or can help, as well as combining that with the traditional approaches where we all go through university and learn the fundamental skills of public health, which is really important. But there are so many ways to do it. Don't be afraid, and bit of Nike, just do it.
Nice. Thank you so much. Popular culture in public health. Awesome. The first couple of questions that came through for our speakers actually have to do with the idea of ethics. And I would just summarize it by calling it science supremacy. So it's interesting because you guys may be able to tell from my accent that I'm actually Chinese American. And so the US definitely in the past few years has had a bit of a crisis with believing in scientists and science. And so this idea that science is on the resurgence, we're now going to listen to science, actually does make some people a little bit nervous, right? Because maybe science has superseded religion. Maybe science has superseded people's basic data privacy. And those were the first couple of questions that were asked. And I think, Jeremy, you have begun to answer it in the Q&A. What are your thoughts about science supremacy and it taking precedence over other considerations?
Firstly, I would urge everyone to read the Financial Times article that I had posted in the link. I do think Harari offers a very thoughtful synthesis of what life 1 year after COVID is and should be. And maybe I can tackle some of the questions around data privacy and really so on also. I do agree that there should not be data monopolies where we concentrate data and the risk is just too high. And I think Gareth is very qualified to speak about federated data models where each part of the system keeps part of the data, but agrees to be able to connect the data so that when the use case it is meaningful, the safeguards are indeed adequate, we can then pool the data together. But we don't run the risk that in the event of the inevitable cybersecurity hack, the data leak, that lives are absolutely ruined because everything I've ever said or done is just out in the open. So I do think that the technology does offer ways to mitigate or minimize risk, but we will not eliminate risk. around, because it's ultimately not about the science, it's about the politics, it's about the political leadership, right? And I think science is one of the factors, certainly one of the most important factors when it comes to really public health, but certainly not the only one. And I guess for us as public health professionals and as voters in our own countries, we should hold our governments accountable to higher standards and really contribute the voice into the public space. If I can take a second to share that about a week ago, the National University shared the media hits. And there were 4 of us who had decided very early on to be friendly to the media once at the start of COVID, because we were afraid of misinformation before infodemic became a buzzword. We were concerned that if we were traditional public health academics and quite media shy, then the space would be filled by everybody else. And wow, I was impressed. Between the 4 of us in the School of Public Health, we did 1,500 media interviews over the year 2020. And I guess that's the commitment all of us should be thinking about to not just producing good science, but communicating good science in ways that engage with the broader public.
Yeah, thank you so much, Jeremy. I'm going to pick up more on the data piece because that certainly has come up in the questions as well. First of all, from a data perspective, I think, there's this concern about the accuracy of data. How do we collect the data? And also the availability of data. I wonder if, Nina, you could comment a bit, especially one of the questions from Gabriel Yan has to do with how quickly data changes. Certainly, we've been caught having to change positioning, for example, on masks based on the data that comes in, and our understanding evolves. From a data perspective, there's three things I want to ask you about. Basically, the availability of data, right? Where do we get it? Is it open source? How do we get data? The second one is, how do we keep on track of it so we can analyze it? And the third one is possibly around the ethics of how we use the data. So all about data, Nina, tell us.
The name of my business is Data Driven Strategies, so I should be able to come up with a reasonable answer to that. And again, I must say that we're definitely here a bit shell shocked. I won't admit that we're not a bit shell shocked from the past year. I wish data has to be available to researchers, all of it. And that means de-anonymized and all those things, but it's not really rocket science to do that. And in the US, we really had to fight for data that we could, race, sex, age, really basic data on comorbidities, on COVID deaths. And we also haven't been able to share that globally very well. So I know that WHO now has a science division, and the science division run by a chief scientist is really focused on how do we better govern data so that we can share it. And that involves technical solutions like interoperability, but also more basic governance solutions on who gets to share. And this idea also that we don't have to aggregate it, different people can own it and we can reach into it. Gareth talked about that. And then about responsible use of data. So I guess I'm moving to the third one. So I think it's great, Jeremy, that you did that. In the US, that space was taken very quickly by a bunch of people. It was really hard to get into that media space with credible information, because I think we learned, as has happened throughout the US history, we're very good at this with the UK, I think. Good journalism doesn't sell papers, but good stories do. And I was surprised at, even in the beginning of the pandemic, and so this doesn't, how did I explain how a virus transmits? And people didn't know the difference between a virus and a bacteria, for example. And we had to really go back to basics, or what is herd immunity? And so I think we need to step back, certainly here, on a very basic level of education about science that we certainly don't have. And sorry, just to get to the data part of that question is that the other part of education that I've had to do as a public health person is explain what meta-analysis are. And the media here very quickly picked up, as you all know, you're all public health people, we have a journal here called MMRW. And the CDC produces it. And the whole point of that journal is to give the weird case study that, like, hey, I'm a doctor. I have no idea what this means. I'm going to put it out for the medical community so that we can concentrate on it. But this idea that a study shows versus really saying the data show or the evidence show, and moving people past that. So availability of data is critical for us, for researchers. And then, again, the problem here is that everybody became an epidemiologist. So there was no quality control on who was publishing what or saying what. I mean, one other example I'll give you is the New York Times, which I used to subscribe to, but I'm protesting still. Because the New York Times started, they said, we don't really trust the CDC data. We're just going to start our own data analysis site to collect data on COVID. So keeping people honest about how they're doing the data. So I don't have an answer. I'm sorry. That was a long ramble about how. I wish I knew. And I'd like to turn the question back to you. What do you think?
No, you're not off the hook yet, Nina. I got one more. So with the data piece, would you say that data is the top priority for precision public health, given the complexity of it, the need for it? Is data the top priority for precision public health?
I'd maybe ask Gareth on that, because it's one part, but the community engagement is also a critical part. Yeah. So data on its own are numbers, but you have to engage with people to understand what's the meaning of the data, what does it mean? And that goes back to the null hypothesis. You have to have a plausible hypothesis or theory of change on what you're trying to achieve. Gareth, over to you.
Yeah, what do you think, Gareth?
No, data is not the most important. Data is a tool. It's an element, and what is most important is the need. So if you understand your need, and that comes from working with the community to define what those needs actually are, because they'll define the needs and the solutions that need to be delivered, then you can aggregate and apply that data in meaningful ways. And then data becomes the key element to serving the need. But data is just data, and more data doesn't mean it's better data. So it's really how do you make use of that? It comes from serving the need and working together with the community to figure out what those things actually are in some sort of meaningful way. So, and that's engagement and that's trust. So I think actually the most important element is trust. If you understand the need, you have trust, you can then do everything else. Sharing data is not a technical issue. There are plenty of technical solutions to share data that through privacy preserving record linkage, data that's federated and you data visit with algorithms visits the data that's interoperable through common data elements and standards. All these things exist. It's about what you're using it for. It's about the needs of the community, and that then needs to be, because the community is the thing that sways the political messaging and the political delivery to some degree, and depending on where you are, a very large degree. And I think one of the other things we've seen in COVID locally, for instance, in WA, is this amazing sort of focus on the importance of public health and saying, this is really critical. And our Premier just gets up every time and says, we're going to do exactly whatever the public health guys tell us to do. When are you going to open this barrier? When the public health guys tell us that it's the right thing to do. And yes, there's still politics and there's still games and there's still all those sorts of things, but I would say 90% of the meaningful decisions are made exactly that way. And I think also key to that has been having very refined, sort of almost like a chain of command through to the messaging in the media. So there's, there really is sort of locally, it's the chief health officer standing up there with the premier of our state, side by side, and saying, these are the messages coming through us, blah, and then the other public health physicians and other doctors then support that messaging, and so I think that's been extraordinarily powerful, and it's been. I really hope that we can maintain what's happened out of COVID in terms of that trust in public health and that trust in science as one part of the solution that you deliver, working together with the community, respecting religion, respecting all these elements. But I think COVID has certainly locally, whether it persists or not, has certainly changed the whole political health dynamic. So I think it's really interesting times.
And maybe Gareth, can I ask you to comment? There's a question from really Stephanie about how the team got the buy-in from the indigenous people. Was it a formal process to build trust? What are some of the lessons learned that may be extrapolatable to all of us who face this challenge with data sharing, getting people to come forward for vaccination and all?
Just having a chat. So really it was saying, again, it came down to need. Is like, we've got this kind of idea. We think it kind of makes sense. Does it? And if so, what should we build and how should we build it? I kind of think we might do this. And they're going to go, well, no, that's not the way what we want. We want this thing over here. And then just taking time. So you must not rush these things. If you have, I mean, COVID can put on obviously time dynamics and things around it, but as much as you can, you must not rush it, and just let the conversations evolve, and listen, and then do something, and do something discreet and meaningful as quickly as you can. So you return benefit. One of the really challenging issues around data management and governance for Indigenous people is this, that so many times there's been no benefit back to the community. People have sort of flown in, taken some data, flown away, done something and got a nice science paper, and really nothing's happened at the community level. So there's this real need to address those elements of mistrust. But also you get solutions coming out of this. So there are now data sharing solutions, there's these things called FAIR, findable, accessible, interoperable, reusable data, Now there are also things called CARE, a nice acronym, which is the Indigenous communities globally getting together and say, yeah, FAIR's great, but you need to think about these other aspects that relate to Indigenous health. So these are the CARE principles, and actually you can use the two together. And so I think it's just those discussions, taking your time, don't rush. One of the big traps, I think, is often if we're doing something under a research banner, and often the research funding is a relatively short period of time, and that creates unwanted dynamics when you're trying to engage and develop a relationship of trust, and making sure that your funding actually supports the elders and the senior people and the youth to actually do the stuff, because often that hasn't been a focus of the funding. It will be, we've got X technology, Y expert, and we want to do this for Indigenous health. And the components of the program that actually make it work get very little or suboptimal funding to actually do that, and to respect the people that you're working with.
Thank you, Gareth. I also think we had some questions too that I think are connected to your work with the Indigenous populations around, how do we help the underserved? I mean, clearly Nina showed some data from New York City, and it's true across the world that there are huge health inequalities, health inequities related to the COVID-19 pandemic. So I think those are all worth thinking about, giving a voice and giving access, both, bidirectionally, access to data on these populations so we can understand how to serve them, and access for them in terms of COVID-19 resources. But Nina, there's a question in here about omics, and we did banter a bit about the omics piece, and it's very, very specific to COVID-19 vaccinations and vaccinations in general. So I wonder, Nina, if you could comment. I'm actually going to read the questions because it's quite complex, but it's very thoughtful. Are there any comments about a relevant omic right now, vaccinomics and adversomics? It is hard to pronounce these things. Precision medicine for vaccine effectiveness and safety. So for instance, for those with rare diseases, we don't know how they would respond to the vaccine, whether they would have any adverse effects. What are the thoughts about these types of omics and application specifically for mass vaccination?
I mean, I guess the question would be around COVID or in general, because I think COVID was done at the speed of light in a way. I mean, if you look at those trials, many of those vaccines weren't even tried on the elderly, who are the target population, who are the people that are dying the most. Yeah. And as you know as well, we haven't tried them on children yet, or we're just starting those trials. And if we want to reach any sort of herd immunity, I mean, in the US, that's about 25% of the population. So I think in an ideal world, we will be able to test subpopulations using everything that we know within our clinical trial work. I mean, I actually haven't really thought about it, to be honest. I think it's a great question. And again, that's where I'm pulled back a year, maybe 10, to say, well, isn't it remarkable that we're not even using the data that we have, which should be driving us in a particular direction, to make really simple decisions. And I think sometimes those discussions can put us a little bit off base. Now, I think the U.S. is also, this will be a great case study in lots of things, in decentralized healthcare systems and why they don't work, why you need a centralized health authority. But another things that we've done, really simple things that you've done brilliantly, and most of the rest of the world has, is just genotyping of the virus. So we didn't do in the US surveillance. We had this weird thing where we focused on percent of positive cases, which if you talk to most public health people, they go like, what? Isn't there bias in the denominator? I mean, even our former president, Trump, said that, and he got sort of laughed. But I think the public health people were thinking, isn't there bias in the denominator? So using just some we weren't doing basic public health surveillance around, testing every 10th person who went to the supermarket. There was no surveillance system in place. And theoretically, I mean, the genotyping, GISAID started that really early. We just weren't doing that. So yes, ideally, I think it's a bit tragic that we can't answer more questions. I mean, we know, for example, there's so many questions that we have about the data on the vaccines and the studies. And I guess with COVID specifically, we're just going to have to wait some time and hope that those questions are being studied as we now have a massive population rollout.
Yeah. Agreed. It's almost like, how long is a piece of string? Where do we start?
Those vaccines also, as you know, there was some of the vaccines only tested in the US, others only tested primarily in white populations. There was a lot, I think one might have done differently again. But given that we are where we are, the best thing that we can do is make sure that those trials continue and focus on risk populations moving forward.
Yeah, I think that then leads to a follow-up question about just the ability to collect data. So after all of these vaccines have gone into arms, what is the ability of governments or public health officials, academia, to track those who've received vaccines so we can do this post-market surveillance? I think we know that we're going to get some loss to follow-up. And in this case, what do you think is the risk to just general vaccine belief in vaccinations and whatnot, and also just in terms of ending the COVID-19 pandemic?
In New York, we're doing a really bad job, and all over the US, on collecting data at all. The CDC has a very simple form, which has where you got the shot. It's got like 7 things you have to fill out, including race. And in the initial data on race, 40% of the people filling out the form neglected to fill in their race category on that form. And we've put forward as public health professionals, we've said to Mr. Biden, you should not be distributing that vaccine to people that can't figure out how to fill in all seven parts of the form. But I know, again, I don't know I don't know in Australia or Singapore, I'm sure you've got better plans to do that than we had here.
If I can chime in, I think that Singapore can punch above its weight in contributing to the post-marketing surveillance, small, compact, and actually relatively aging also, and with incredible data. Nobody can get a vaccination without filling up the form, right? And because because Singapore has a unique identifier called the identity card system, we in theory can pool data from multiple sources to then look for rare events and to look for the risk factors that may have contributed to some of these events, even no matter how esoteric they may actually seem. So I'm not privy to what exactly is being collected, but certainly I do think Singapore can contribute in this space and put out papers that can help to guide the rest of the world, because we have the infrastructure to do so.
Gareth, how about Indigenous populations or overall in Australia? Are the right data being collected to support vaccination efforts?
So I think there's a fundamental issue when it comes when it comes down to Indigenous health and counting. In that, often Indigenous people are not counted, either because you have Nina's example where that, for a range of reasons that I can think about, a number of different range of reasons why that's happening, is that that information is not offered up, or it's not actively sought, or it's not done in a standardized way. And so we know when people have looked at cancer, for instance, and looked at coding of Indigenous status, that it's woeful. And what that means is that all your monitoring and your interventions have a false denominator, which is what Nina talked about. So it's actually critical that you are counting Indigenous status, and the best place probably to do that is in the health system, and so it's how you do that better. Because after all, if people aren't counted, then they're going to feel like they don't count. Yes. So I think that's probably almost the most fundamental issue for any health system about Indigenous health care at a systems monitoring level is actually the counting of Indigenous status. And then there is all the cultural considerations about and barriers or enablers to that actually happening. So I think that counting question is fundamental. The other thing from a Western Australian perspective is that we have this linked data universe, essentially. So our health systems are linked to our justice systems data, are linked to our educational systems data, and so we have all these data sets that we can link in a privacy preserving way to do whole of population studies on outcome X, Y, Z. And so similar to the Singaporean status, with a rather than having a single health number, people can be tracked and counted in a de-identified way to do whole of population studies. So I think there are also, there's a really nice complementary opportunity between Singapore and, say, Western Australia or other places, and something I'd love to explore some more. Our data linkage infrastructure has had a massive revamp. It was happening anyway, and then of course COVID came along and supercharged everything. And so I think there are opportunities to explore exactly that.
Yeah, thank you, Gareth. I'm going to actually move on to our final questions. Our time is almost up, and I love the way the word you use, supercharge. So my final question to the three of our speakers is, what would it take to supercharge precision public health? What do you think success would look like for us in the next, say, 5 years? Gareth?
Youth. So I think youth are superchargers. They're brilliant. They're enthusiastic. They're driven. They're motivated. And their minds aren't dogmatic and haven't been fettered and institutionalized. So I think it's, how do we engage and learn from, because I think the solutions are going to come from youth. And I always think go to where it's hardest, because that's where you make. So go to the area, the greatest unmet need you can think of, and start there. You'll deliver solutions that are robust and then are generalizable other ways. And if you build a solution that works for someone who's incredibly well resourced in a beautiful setting, and et cetera, won't necessarily translate to the other way. But many times, if you make the solution that works robustly in the most challenging domain, you're going to get a solution that will work for everybody.
Thank you very much. Nina, what do you think would supercharge precision public health, and what would success look like?
It would take a longer time period than 5 years, but I think we should start teaching public health in high school. I think we should start teaching principles in public health in high school, because as Jeremy said, I think COVID has shown that everybody really should understand a little bit of good old-fashioned public health, and not just one subject of it, infectious disease epidemiology, but kind of the whole system of public health. So I think that's what I would do. And in the meantime, I would at your School of Public Health propose a crash course for mayors, policymakers, and decision makers.
Oh, that's a good one.
To just kind of get up to speed. And that's maybe my supercharge element.
Excellent. Thank you. Jeremy, what's your supercharge element?
it's also the reason why we're hosting Precision Public Health in April, meaning that's a month away, and that's really making precision public health useful. In the conference, we have deliberately invited traditional public health people as well as representatives and leaders from the tech giants, Amazon, Google, Facebook, and their Chinese counterparts. And the whole logic, I mean, everyone knows that the tech companies conduct a massive amount of surveillance on all of us, but we accept it because it's useful, right? So we do have to make the use case very plain that people say, I'm not 100% comfortable, but I'll take that leap of faith. And once people have entrusted their data with us, we have to be completely rigorous and religious about safeguarding this and to make sure that over the next 5 years, there are no major data breaches, that the system works. And we can balance the use and the trust very nicely. Then I think these are the twin engines that will turbocharge precision public health. You're on mute now, Xian.
I was typing. But a great way to end the session. I wanted to let everyone know I put in the link to the Precision Public Health Asia conference for you. It is complimentary. Please do sign up. We look forward to seeing you. And I do like to give people a little bit of time back after a very long webinar. Thank you so much to our speakers today, Gareth, Nina, Jeremy, for sharing your thoughts, insights, and just getting us super excited about the future of public health and precision public health. Thank you very much, everyone, for joining.
Thank
Thank
you
you so much.
All right.
Bye-bye.
Have a good day.
Yeah.
Bye.